We're back. How you going, guys? I'm back again. You guys saw me last video, but today I'm here with Matt, the ghost Matt Seal.
You don't have to put in.
And today we'll be going through the heart. Today we're going to go through the heart and everything about the heart.
Oh.
Alright.
Okay.
So, Matt, you take over?
Okay. I think we should. Do you want to start with the heart first? Should we start with the heart? Because that makes more sense.
Let's start with the heart, the general heart.
Okay.
We'll start with the heart and the blood.
Do you have black? Do you want to draw on black first?
Wait, why is one thing to the heart?
Yeah, if I can draw on. Okay. Don't judge my drawing, guys. Like it's a learning experience. Hey, hey, hey! It works. It works. No, he's just judging.
How's it watching spawning? Finding good. I'm watching it now. I'm gonna watch it now. Like right now, after this.
Not bad.
I should have drew it before. You're right. And then we'll do. I'll just draw it. Okay. Let me draw this. I'll draw a line as a separator. Sahil, could you please be quiet? Okay. Okay. Let's label this. So this is the apex of the heart, right? So this is going to be our right side. I want you to think about it, guys. That's going to be our right side. This is going to be our left. Okay? So I'll start with here, obviously. This is our pulmonary veins. Okay? Our pulmonary veins are going to be bringing oxygenated blood back to the heart and going into the left atrium. Okay? We'll get to the left atrium. This is also the pulmonary veins. I'll just write PV. Okay? Okay? This is the aorta. Okay? This sends the oxygenated blood to the rest of the body. Okay? We'll get to in more detail later on. Okay, thank you so much, Shritik. Now we've got the superior vena cava and inferior vena cava. These are veins that bring deoxygenated blood back to the heart from the rest of the body. So, let's try this. Okay. Now, okay. Who wants to do it in red? Well, okay, he will be labeling while I talk now.
You'll see why in a bit.
Okay. Can you label while I talk now? Okay. So this is going to be the right atrium.
Oh,
You
you
label
label
right?
it?
Yeah, just I in red. Don't you want to do it in red?
The right, you'll see why it's in blue.
Okay. Just continue.
Oh, you want me to go through now?
No, that's right. Okay. This is the left atrium. Left atrium, left ventricle.
Red.
Okay. Sahil's laughing in the back, guys. He's losing aura as we speak. Okay. So what's going to happen is, I'll start with blood's going to be pooling from the rest of the body, from the inferior vena cava, from the inferior, your lower limbs, your trunk, and also it's going to come in from your upper, so your upper limbs, your brain, through the superior vena cava. So this is deoxygenated blood. That's your step one. Okay, so it's pulling in, and it's pulling in into the right atrium. So I'll put one in. Okay, then you have something called your tricuspid valve. I'll put T for tricuspid. Okay, 3 flaps. Cuspid means flaps. Try 3. Okay, and this goes into the right ventricle. So what happens is deoxygenated blood comes in from the superior and inferior cava, goes in the right atrium, then moves to the right ventricle. Number 2. Okay? Then, this being our pulmonary trunk, I forgot to mention. Our pulmonary trunk, right, takes oxygenated blood to our lungs. Okay, you'll see what happens now. So our right ventricle is connected to our pulmonary trunk. And what happens is, the right ventricle would take deoxygenated blood, send it to the pulmonary trunk, and this will go to the lungs. Once it goes to the lungs, it will become oxygenated. Then once it becomes oxygenated, this is going to be our step 3. It's going to come back through our pulmonary veins. Okay, we'll label that step 4. Okay, so now we've got oxygenated blood, and you're going to say, where does it go into when the oxygenated blood comes back through the pulmonary veins? It goes into the left atrium. So now I'll label this 4 because we've got our blood in our left atrium. Then we have something else. So if we have tricuspid on that side, we're going to have bicuspid on this side. Okay? Bicuspid, two cuspid flaps. Okay, it's a bicuspid flap. It's a valve that opens and closes, regulating the blood flow between the atriums and the ventricles. Okay.
Also called the mitral.
Correct. Mitral. Yeah, in some textbooks they call it mitral. Okay. So now we've got it in the left atrium. Blood will move from the left atrium, that's oxygenated, into the left ventricle. This is our step 5. Okay. Now this is our final step. Your whole heart will contract, and from the left ventricle, it will flow out all the way through the aorta to the rest of the body. That's step 6. So your final step is the oxygenated blood gets thrown out to the aorta into the rest of your bodies to oxygenate your tissue. Okay, so just a recap of real quick what happens. Superior and inferior cava, superior vena cava and inferior vena cava, deoxygenated blood, right atrium, pulls in there, tricuspid valve, opens up, goes into the right ventricle. Right ventricle sends the blood to the pulmonary trunk, go to the lungs, it will get oxygenated and come back through the pulmonary veins on either side. And then these pulmonary veins will go into, will pull into the left atrium. And then this left atrium has a bicuspid valve that leads to the left ventricle. The oxygenated blood will go from the left atrium to the left ventricle. Then the left ventricle is connected to the aorta, and the oxygenated blood will be sent from the left ventricle to the aorta. I forgot to add something. I forgot to add these semilunar valves. Okay, so when I said we have pulmonary trunks, right, these also have valves. From the right ventricle to the pulmonary trunk, there's a valve here. That's called your pulmonary semilunar valve. Your semilunar valve, semilunar. Okay, it's like that. So what it is aimed there to do, as soon as there's backflow, so as soon as there's backflow, it will close off. It will catch it and close off. Okay, so that's all. We have a pulmonary semilunar trunk, pulmonary semilunar valve between the right ventricle and the right pulmonary trunk. So we'll say here, we'll call this the pulmonary semilunar valve, PS. And we also have one from the left ventricle to the aorta, which is called your aortic semilunar valve, which is here. I'll label that AS. So whenever you think of ventricles, the ventricles always send stuff through the semilunar valves. The atriums always send stuff through the tricuspid and bicuspid valves. Okay, that's really important, guys. Okay, what are we going to do now? So do you want to do...
Should we do the heart anatomy?
Yeah, sure. I kind of did the blood flow.
Yeah, I
Okay, you could have told me.
It's okay.
Okay, now we've kind of done that. Okay, we should do the heart anatomy.
Yeah.
Okay, just label what happened. Do you just want to say what's in the right ventricle?
Yeah.
Individual?
We can start with this one.
Is this me or you? Oh, it's us both. You want to start off?
Yeah. Okay, yeah. So generally, Matt's already mentioned all of the main structures. So you got the right atrium, right ventricle, left atrium, left ventricle. If you remember back to why I did it in red and blue, so anything in blue is deoxygenated blood. Anything in red is oxygenated blood. So the right side is all deoxygenated blood, left side is all oxygenated blood. This line through the middle is also known as the septum. That separates the right and the left side of the heart. Yep, so pulmonary veins. A lot of people get confused about this. So when we talk about pulmonary veins and pulmonary arteries, because they are different to the rest of the veins and arteries of the body. So when we talk about pulmonary veins, they are oxygenated blood, Whereas pulmonary arteries are deoxygenated blood, whereas in the rest of the systemic circulation, it's the other way around. Because we're talking about the lungs, right? We're talking about what's going towards the lungs, what's going away from the lungs. So pulmonary veins, they're going away from the lungs, the same way normal veins are going away from the heart, towards the heart. And then arteries, they're going towards, so the pulmonary trunk, also known as pulmonary arteries, they're going towards the lungs, whereas the rest of the arteries of the body are going away from the heart. So they're basically just the opposite way around. Alright, and then the heart itself, it has multiple layers. It has the pericardium, and the pericardium is basically the biggest layer on the outside.
So,
Yeah.
so there's Okay. So, just going on from Shritik, right? So we got the pericardium. Your pericardium will be your connective tissue, your collagen and fibers. Okay. Then your next layer will be your myocardium. Myo, muscle. It's your cardiac tissue. Okay. If you want to do that, another cardiac. And then your final layer is your endocardium. Endo, or I always remember, it's the inside layer, endothelium. Okay? So your endocardium has endothelial, your myocardium, which is your middle layer, has muscle, cardiac muscle. Your top layer, your pericardium, has connective tissue. Okay? And you also have, between the heart, you always have a pericardial cavity, right? It's just a little gap between these layers, particular layer, in between, like there, pericardial. There's also some fluid in there that helps lubricate, because remember your heart's moving very fast, we want to reduce the friction. Okay, talk about the layers. We'll continue from the heart, what we're talking about. Okay, so I'll do that. So between the tricuspid valve and bicuspid, they're both right. So the valve is like, I'm going to try to draw a valve. So this is a large tricuspid valve. I'm going to try to draw just the main point of what it is. So it's an opening, right? Either side, you're going to have I'm going to try to imagine it closed. Pretend this is closed. And what I'm drawing is something called chordae tendineae. Chordae tendineae is something that attaches to the flap. It's like strings. You know how you play with a puppet and you can move the puppet using the strings? Exactly the same with this flap, right? So with this flap, this chordae tendineae attached directly to the flap, and we can able to close and open the flap. But you're wondering, if it's just connective tissue, how are we going to move it? That's why there's muscle attached to it. So we also have papillary muscles attached to it. Okay? I'll draw it like this. Just pretend papillary muscles are just attached to these chordae tendineae, ultimately the flaps, which contract and help open and close the flaps. Okay? So your papillary muscles, your chordae tendineae that attaches to these flaps, and ultimately what these are trying to do is open and close the tricuspid and bicuspid valves. But we also have something called trabeculae carnae. Trabeculae carnae is in between, is in these right ventricle and left ventricle. It's like the wall, right? The trabeculae carnae is just, it's like almost like, it looks like a porous wall, like there's a bunch of bubbles in it, okay? And what this does is this prevents backflow. So it helps with assisting preventing backflow, but it helps maintain the pressure, okay? You will see that in anatomy. If you see it, it's like a wall. There's the wall of the right atrium. You've got like we'll have like that, okay? That's what you'll see, okay? That's your trabeculae carnae, okay? Anything?
Just to touch on this one, so these tendons and stuff, they prevent the valves from prolapsing. So going into the ventricle valves, they will sometimes prolapse into the atrium. So these chordae tendineae, they prevent that from happening.
Exactly.
Keeping it nice and tight.
Exactly.
So should we do coronary arteries?
Yeah, we can, and we're also going to do aorta. I can't forget that.
We can do the aorta first.
Okay, so we don't forget it. Okay, so I remember A, B, C, S. So your first one is going to be your aorta. Right, your aorta is going to be this. Sends oxygenated blood away. The next is your brachiocephalic, right, which is going to be the first one. Let's label this 1 to make it easier. It's going to be brachiocephalic. And what's just really interesting about your brachiocephalic, it actually branches to 2 things. And you're wondering what are these 2 things? We'll get along to when we go to CNS. Okay? Okay, so next is, you've got your carotid. Okay, that's going to be your second one. And what's really important is, I told you this is the left side, and this is the right side. So this is the left side, this is called the left carotid. I'll say LC. Okay? And then on the S is going to be your subclavian. Your subclavian, remember, it's always on left. I'm talking about the left, so this is going to be your left subclavian. Now you're wondering, why am I labeling it left? Obviously because there's a right. So that's where I get the 2 branches from the brachiocephalic. You got your right carotid, and you got your right subclavian. Okay, so aorta branches into that. Okay? So I'll just kind of go through this as fast as possible. Next.
Yep, okay, then we'll just touch on the coronary arteries of the heart. So the 2 main ones are your right descending artery here. So that's the main one that comes out from the aorta. So these will come from here. If you go back to this here, these will be where your 2 right and left coronary arteries will descend from. So these will basically come down here, your right and your left, like that. So this is your left descending artery. That is this whole thing going down here. This is your circumflex. And these are your marginal. So these are all left side. One of the main ones on the right side is the posterior descending artery. So it's right, but it's your PDA. So it's a posterior descending artery. So that'll go to the back of the heart, right from here to the back. Those are the main coronary arteries, carrying oxygenated blood. And then you also have your coronary veins. That'll just drain back into the coronary sinus. So the coronary sinus is around here. The coronary sinus. So that's where your coronary veins will drain all the blood. That's deoxygenated. That's just a quick touch.
Okay, I'll just quickly mention the other one. So you got your posterior descending artery. You also have your anterior descending artery in your left coronary arteries. And also you have 2 more here. You have your acute marginal artery, and you also have your sinoatrial artery, okay? And yeah, and he also mentioned the circumflex, that's good. So those are just arteries that, remember, if we're feeding the rest of the body, right, we need to feed also our heart. So that's where the aorta through diastole, right? So when your heart relaxes, we're actually, blood flow is flowing into the coronary arteries and feeds the myocardial tissue in the tip, right? And ultimately, now we're going to talk about the coronary veins and what happens. We'll talk about the coronary veins. We'll talk about the coronary veins. I talked about the coronary arteries.
Yeah, so what Matt also said before, the rest of the body will be supplied with blood during systole, whereas the only thing that isn't is the coronary arteries, which are through diastole.
Okay. So the whole point with our pulmonary veins, right? Remember, like Shritik said,
Coronary.
Yeah, coronary veins. So like Shruti said before, away. So I think when we talk about coronary arteries, it's away from the heart, but now we're going towards the heart. So it's bringing it back, right? So the coronary veins are just getting all this blood and putting it back into our system to be oxygenated again. Think about it as deoxygenated blood now. So our pulmonary veins, we've got like our coronary veins. We've got like our great cardiac vein, we've got our middle cardiac vein, and we've got our coronary sinus. Okay, so it will be like, sorry about the image, I'm thinking about it at the bottom, so I'm looking at it at the bottom, it will be something like this. Okay, sorry about the bad image. But this is like the great cardiac vein, and then you have your coronary sinus, and you'll have your middle cardiac vein, if we're thinking about the bottom of the heart. Okay? And what happens is all these coronary veins that have deoxygenated blood eventually pull into the coronary sinus. So this is think about this, the coronary sinus. It will pull into the coronary sinus, and what will happen with this blood? It will go back into where's all our deoxygenated blood going? Right back to our right atrium. Okay? So we went from our aorta gives our coronary arteries blood, oxygenated blood, gets used up in the myocardium and tissue, coronary veins sends it back to the right atrium to be reoxygenated. Okay? So we've done blood flow, we've done the heart, we've done the heart. So we'll just cross these off. We've done the heart.
Move to the pressure.
We can also talk about the baroreceptors as well.
Yeah, we can do that. Yeah, so now we'll just quickly talk about the pressure as it moves through the systemic circulation. So obviously, where do you think the highest pressure would be? In the left ventricle. Why? Because this is where the blood will go right before it's pumped out to the aorta to the rest of the body. So the highest pressure is in the ventricles. That's the storage in the heart of blood. And then aorta, that's the next highest blood pressure is in the aorta, and that is where we will talk about baroreceptors in a bit, the aorta and the carotid arteries. And then you have your distributing arteries. So
you have your conducting.
Conducting arteries. So these are your big ones. These are your big arteries. So your aorta, your carotid, brachiocephalic. These are your big arteries. So these are the next highest, and then you have your distributing ones. So these are your small arteries, like your radial arteries, things like that. And then you have the transition from arteries to veins. So there is something in the middle of that, capillaries. So how it works is you'll have your artery here.
Don't forget arterioles.
Yeah. And that will basically transition into these smaller ones here. These smaller ones are called arterioles, right? And they are. This is where the biggest pressure drop happens. From artery to arterial is the biggest pressure drop you'll see in the curve. This will basically become capillary. Capillary is where all your gas exchange happens. And then you will have your venous side. So these are your venules into your veins, back to the heart. So this is basically how blood will flow in the systemic circulation. Veins and back to the inferior and superior vena cava. And pressure, so pressure will start high here. It'll start very high in arteries, drop massively in arterioles, and then capillaries it'll have low, and then venules it'll go up a little bit, and then that's it. A major thing that veins have to go against, and this is a structural component of veins, is they have to go against gravity. So you can see here inferior vena cava has to go against gravity. Veins have this specific structure that we've talked about already. The flaps, so they are the
Tricuspid.
The valves. So veins have valves. These veins prevent vein valves prevent backflow. So they're basically going to look like this. Yeah, they're going to look like this. So once the blood goes through, these cannot contract back, and it prevents that blood from coming back again. So once they go in, they cannot come back. So that's something veins need that arteries don't have, because arteries already have enough pressure.
Okay. I just want to add as well, because Shritik said that the left ventricle, the left side really has the highest pressure. That's why it's 3 times thicker than the right. So this tissue here is going to be thicker than the right, to accommodate for that increase in pressure and allow it to contract, to move out of the airway. Okay, I think we're going to rub this all off, and then, what do you want to do, hydrostatic and osmotic?
Oh, we can just do that anyway. Yeah. So hydrostatic and osmotic or oncotic pressure, you might hear, colloidal oncotic. They're basically the pressure differences from blood flow to interstitial tissue. So in the arteries with all the blood vessels, you have hydrostatic pressure. Right, hydrostatic pressure, and it's the highest pressure. So this is what is the main determinant for how oxygen and stuff move into the interstitial tissue or fluid, and I think it's around 40. I believe.
30.
30, yeah, 30 to 40 millimeters per thing. And then interstitial hydrostatic is this way, very low.
Yeah.
I'm pretty sure it's 0 or 1.
15. That was
Okay, are you sure?
20, sorry. 20.
Yeah, it's
No,
pretty low.
it's 20. Yeah,
If this was higher than that, it'd be constituting
Yeah.
backwards, and you don't want that.
Mhm.
That's why this is a gradient here. Gradient is net downwards, and then your oncotic. This is due to oncotic basically means proteins. So this is due to proteins. Now proteins pull water, right? Proteins pull water. So oncotic basically works the other way. So it'll be like this. Oncotic going in, I believe, is 1.
Oh no, it's
It's like
it's constant
0
but
and
on the
1.
vein.
It's pretty low.
Yeah.
The biggest one is hydrostatic. That's the one we have to remember.
Okay.
Oncotic or osmotic. You might hear osmotic. They mean the same thing.
So we've done hydrostatic and osmotic. Do you want to move on to? Do you want to talk about baroreceptors now?
Oh yeah, baroreceptors. Oh, you can do it. Yeah.
So baroreceptors, we have some in our carotid and aortic. All they're measuring is like, we have this huge amount of pressure, like we're talking about before, where Shritik said the left ventricle is under huge amounts of pressure. How are we going to regulate this? Okay, our baroreceptors, okay, they are going to ultimately detect that change in pressure, and ultimately they adjust it very quickly. They're from beat to beat, where the heart contracts and relaxes. It quickly adjusts it. And how it adjusts this is it has stretch receptors. So in your arterioles, you have stretch receptors. Okay? And these stretch receptors, these stretch receptors are being the baroreceptors, right? So they measure stretch, that's what I'm trying to say. So the higher the stretch, let's say there's an increase in stretch, it's telling the baroreceptors there's a lot of pressure. So they'll send it back to the brain and tell the brain, we have a lot of pressure, what do we do? So then ultimately the brain will decrease its sympathetic response and increase its parasympathetic. But ultimately what I'm trying to say is our baroreceptors are telling our brain if there's too much stretch in the arteries or too little stretch in the arteries. And our brain will then adjust our sympathetic and parasympathetic accordingly. Right? There's your sympathetic contraction to increase the pressure, parasympathetic relaxation. So here we've got too much pressure, so we're trying to decrease the pressure. How do we decrease the pressure? We increase the parasympathetic response. And this parasympathetic response, acetylcholine will be released, bind to beta-2 receptors, vasodilation, trying to decrease that pressure. Okay, that's all the baroreceptors are.
And baroreceptors are always firing. An increase in pressure means there will be an increase in firing, so increase of stimulation. So they're always firing, just increase with you.
Done hydro. Should we move on to the cardiac? So we've done baro, done cardiac.
Yes.
I can do the mean arterial just here, so
Yeah.
we don't have to. Do you want to start rubbing out? Rub out that and I'll do it here. Let me just rub this out. Okay. Start rubbing out that ball, I'll go through. Okay, you can still see me, Ilhan, in this area? Thank you very much. So now we're going to go through mean arterial pressure. How do we measure this? It is diastolic, I'm going to represent as D, plus, so how do we calculate this? Diastolic plus 1/3 times systolic minus diastolic. That is the calculation of mean arterial pressure. And it's usually between 60 and 100 of mercury. Millimeters, I think. That's it. Okay. Now, mean arterial pressure, as it says, the average pressure within the arteries. And now I'm going to talk about how this, what affects this mean arterial pressure right now. So, your mean arterial pressure is calculated from your cardiac output times your total peripheral resistance. And your cardiac output is calculated through your heart rate, which can be adjusted through your ANS, autonomic nervous system, and your stroke volume. Your stroke volume is your diastolic, end diastolic volume minus end systolic volume. It's how much blood you're pushing out with each beat, okay? And then your total peripheral resistance is how much resistance that blood is getting as it's moving through these arteries. Now let's break it up. We're going to break up what affects stroke volumes. This all affects mean arterial pressure, right? D in the calculation. We got preload. Preload is the initial filling of the heart. When we fill the heart, what we're going to go through now, when how much how much blood goes into the right atrium, will ultimately determine how much blood we can pump out. Am I correct? Increase in preload, increase in stroke volume, how much we can pump out. Then we go to contractility. Remember, the stronger the heart contracts, the more it's able to pump out. So that's where contractility comes in. Then we've got afterload. What does afterload mean? The heart is contracted and the blood is moving through the aorta. How much resistance is that blood getting? So the higher the afterload, the lower the stroke volume. So that's inversely proportional with stroke volume. Okay. Now I want to mention preload also has factors that affect preload. We got venous return. How much blood is coming back from the venous system? We also got gravity. So if we have an increase in venous return, increase in stroke volume. If we have gravity affects us also by trying to decrease our stroke volume. So that's inversely proportional. And then we got your muscles. So when you move around, your muscles are contracting. As they contract, they're also squeezing the vessels, allowing increase in pressure and them to move upwards, right? Back to the heart. Then we got a respiratory. Now I'm going to talk about your intrathoracic pressure within your thoracic cavity, right? If there's a decrease in intrathoracic pressure, if I have all the blood pooling in my legs, and there's high pressure there, it will move from high pressure to low pressure. So that's why with a decrease in intrathoracic pressure, it can help bring more blood back to our heart and increase the stroke volume. Then we've got total peripheral resistance. Like I said before, how much resistance the blood is getting when it's trying to go back to the heart. And this can be done by radius of the vessels. This is inversely proportional, right? So the increase in the radius, the decrease in total peripheral resistance. Then we've got viscosity. Viscosity is directly proportional to total peripheral resistance. Increase in viscosity, increase in total peripheral resistance. Then we've got length. That's also proportional. So the increase in length, increase in total peripheral resistance. Okay, just trying to get through this as fast as possible. I've got 7 minutes. We'll do 10 minutes. Oh, 20. I don't mind if I'm late. Okay, now we're going to go through. So we've done, I just quickly mentioned that. Do you want to go through ECGs? Or do you want to do cardiac first?
together.
Do we do cardiac or ECGs? We'll do
Cardiac
ECGs.
first.
Okay, we'll do, just goes up there. Do you want me to do cardiac? We'll do it together?
Yeah.
Okay. So we talked about, right, the flow. Actually, we should do ECGs directly.
Yeah,
Yeah. So we talked about the flow of the heart, right? Where the blood flows. We should also talk about ECGs, how we measure, right, our blood, really how we look at the heart, right, in the medical setting, right? It's called electrocardiogram. Electrocardiogram means we're measuring the electrical signals within our heart, right? Because remember, the electrical signals within our heart are ultimately stimulating our heart to contract. Okay, so if we measure that, we can see our heart, how our heart is going, right? So we can measure our heart. Okay, so what Shritik drew is what we'll see in the ECG. Okay, and we're going to go through, like I told you before, where the electrical, where the blood flows. Now we're going to go through with the electrical. Do you want to go through the electrical? What happens?
Yeah.
Because we have two. We'll go through the notes.
Okay, yeah, sure. So the electrical conductivity of the heart starts from the sinoatrial node. So this is basically the pacemaker, what sets your heart beat. Okay, so this is situated around here on the right side of your heart. Okay, so that's the first step, is the sinoatrial node. This will go to your atrioventricular node. So there will be a direct signal from the sinoatrial node to the atrioventricular node. Now remember, the sinoatrial node will depolarize this whole area, so pretty much the whole atrial area. Okay, and then the atrioventricular node is just situated between the atrium and the ventricle, around the septum. Okay, so the middle. Now this one, the atrioventricular node, will send a signal down the septum, right? And it'll travel down here and then back up through the heart. So it'll look something like that. We'll go into more detail later. But this is basically the simple form, and then these ones here, these electrical conductors are called Purkinje fibers. Basically the rates, so this one's 60 to 100. That's why your heart rate should be around 60 to 100. This one I think is around 40 to 50 into the rest of the Purkinje fibers. Okay, so that's basically.
Do you have class in that?
Yep.
Okay, this is part 1. We'll continue this on later.
Yeah, we'll continue.
But Shritik has to get to class.
Yes. Thank you guys,
Thank you.
and we'll see you next time.